Hi students, this is Mrs. Egler, and today we are going to go over chapter 36, which is nutrition. Um, we know as individuals that good nutrition is vital for our life and health, and we also know that poor nutrition can seriously decrease one's level of wellness, which is why this is an important topic to go over as far as nursing. Some of the things we're going to go over in this chapter are just the basic principles of nutrition. We're going to focus on nutrients, energy balance, choices of adequate diet, and factors affecting nutrition today. So, principles of nutrition. We know that the study of nutrition is the study of how food nourishes our body. So, when we think about nutrients, we are thinking about substances used by the body for growth, development, activity, reproduction, and recovery. We know most nutrients work better together than on their own. Nutrients or the nutrient needs we have will change throughout our life depending on our age and our health status. Um, the book talks about essential nutrients, and these are not synthesized in the body or produced in large enough quantities, so we must have these provided in our diet or as a supplement. The book goes on to discuss macronutrients. So, macronutrients are needed in large amounts, and these include our carbohydrates, our proteins, and our fats. And these are our energy supplying nutrients. Micronutrients we need in smaller amounts, and these are things such as our minerals and our vitamins. Um, and we also know that this last sentence here, that we have three nutrients that they are kind of responsible for regulating our processes. And those include water, minerals, and vitamins. So when we think about energy or energy balance, the body needs energy to function, and we obtain this energy from the foods that we consume. Calories, if you hear the term calories, that is just a measurement of the energy that is in our food. And as I said on the previous, we have three energy supplying nutrients, and those are the carbohydrates, proteins, and fats that provide our energy. Energy is needed, as I said, to carry on all activities. A person's total daily energy expenditures is the sum of all the calories used to perform physical activity, and we have to have calories included in that to maintain our basal metabolism, to digest, to absorb our food. If our daily intake is equal to our total daily energy expenditure, the person's weight will relatively remain stable or the same. But if we have amounts of energy taken in is less than the amount used by the body, one tends to lose weight. And likewise, if energy intakes exceed energy expenditures, you will see a person's weight increase. So many of you, I'm sure, have heard the term metabolism. And when we think about metabolism, our basal metabolism is our energy required to carry on our involuntary activities. So these are the things we're not really thinking about, like maintaining our body temperature or our muscle tone, producing or releasing secretions, our breathing, our circulation, and our GI functions. We know that men tend to have a higher basal metabolic rate than women do, and this is somewhat due to the muscle mass that they have. Factors that will increase our basal metabolism through life is growth, infections, fever, emotional tension, extreme environmental temperatures, and hormone elevations are just a few examples of factors that will increase that metabolism. Factors that will decrease our basal metabolism rate is prolonged fasting, aging, and sleep. We know that very low calorie diets, they tend to slow metabolism and ultimately make it more difficult to lose weight. This is important to know when we're dealing with patients. Maybe we have an obese patient who's been trying to lose weight, and as we look at what their diet consists of and how many calories they're taking in, it could be a factor that they're not taking enough calories in and they're doing more of a prolonged fasting. And like I said, that can slow their metabolism and make it more difficult for them to change and lose weight. The next term I want to review in this slide is body mass index, or BMI, you may hear it referred to. And this is just a method of establishing what our body fat stores are. And what we're doing with the BMI is we're trying to determine the ideal weight as an estimate of optimal weight for optimal health. Um, a lot of times when a patient comes in and we put in their weight and height into our technology or our computer systems, it will give us the patient's BMI. It will equate it for us. There is a method that we can do that. This is the equation for that. We will not ask you, you do not need to memorize this equation. We are not going to ask you this on the test. But if you do want to take a few minutes while you're listening to this PowerPoint, stop it and use this equation to try to figure out your own BMI. You are welcome to see where that falls. Basically, with this formula, you will need to convert your it's weight in kilograms. The BMI is converted weight in kilograms by height in meters squared, or weight in pounds divided by height in inches squared times 703. So if you want to take a few minutes and work that, you can before you jump to the next slide. So I don't know how many of you took the time to figure out your BMI or your body mass index, but this is a table from your textbook, table 36-1. And what we have found with body mass index and why we calculate it is we have found that there is a risk of obesity associated diseases and conditions that we can relate to by the BMI and waist circumference. And so I know when I have calculated mine in the past, I am at risk of some of these obesity associated diseases because I fall into that obesity class. And probably many of us do. Americans tend to be more overweight, and there is a huge health concern about Americans' BMI and their waist circumference. And I know in the last slide I was mentioning BMIs with waist circumference. Your waist circumference is just measuring the circumference of the client at the level of the umbilicus, so their waist. This is a good indicator of how much abdominal fat. What they have found is that an increase in abdominal fat increases the risk for type 2 diabetes, heart disease, high cholesterol, and hypertension. And the higher risk is associated with a waist greater than 40 inches in men and a waist greater than 35 inches in women. So as we continue on thinking about energy balance, we've went over some of the terminology as far as BMI, waist circumference, what is our metabolism. And so, as we stated, we are going to move on to the energy providing nutrients. And the major or the big one is carbohydrates. This is an essential nutrient. And we most commonly think of carbohydrates, or they're known as sugar and starches. Their structural framework of plants, animal sources, lactose or milk. What we know about carbohydrates is they are the most abundant and they're a least expensive source of calories. And so when you think about that, that would be important to know, especially when determining a diet of possibly a lower income patient. And maybe that patient is having some weight issues. Maybe they are more obese. And we have to think about, if they're in the poverty level or a lower income, they're probably more likely to be purchasing the more least expensive sources of calories, and which would be their carbohydrates. We can break down carbohydrates into simple carbs and complex carbs. Um, Carbohydrates are more easily and quickly digested than protein and fats. And so carbohydrate intake is often correlated, again, to income. As incomes increase, we also see a correlation of carbohydrate intake decreasing. As we continue to talk about our carbohydrates, it's important to realize that 90% are digested and they're converted into glucose. Um, And the main types of carbs, as I said in the previous slide, are simple and complex. So, a simple carb are sugars that the body can use right away, and they tend to raise our blood sugar very quickly. Where a complex carb, it has to be broken down into a similar form before they can be used for energy. It takes these foods longer to affect our blood sugar. And most of the time, your blood sugar does not get as high as it would with these foods. So, this is important if we think about a diabetic patient, and what we're trying to educate them as far as dietary needs or intake. Um, diabetic patients have to count carbs to help control their blood sugar. Energy provided for 1 gram of carbohydrate is 4 calories. But we would want to teach our patients that it's okay to have carbs, but we would want to assist them with choosing more of the complex carbs to have in their diet versus the simple carbs, because that way their blood sugar is not shooting straight up right away and it's more even. And so I want you to take a minute and I want you just to jot down some examples of what you think of when you think of simple carbs and what you think of as far as complex carbs. And we will share that when we meet on in our class to discuss this when we're going over this topic. So, as I stated, when we were going through skin integrity and some of our other chapters, is that protein is very important for sick or post-op type patients, those that have skin integrity issues. And the reason is it's required for all formation of body structures, including our genes, our enzymes, our muscle, our bone matrix, our skin, and our blood. So, if we're having alterations such as skin integrity issues, we're going to need more protein in order to rebuild and form that. Within the body, there's more than 1,000 different proteins, and they're made up by combining various amounts and proportions of the 22 basic building blocks known as amino acids. There's 9 essential amino acids that can be obtained from the diet. The other 13 can be made by the body. So when we think about dietary proteins, we have complete and incomplete. So complete are high quality proteins. They contain sufficient amounts of all the essential amino acids. And these type of foods are going to include eggs, dairy, meats. And then we have what's called an incomplete or a lower quality type of dietary protein. And the reason that it's incomplete is it's deficient in one or more of essential amino acids. So these can be, when we think about foods for this category, would be your grains, your legumes, your vegetables. The thing to remember is, people choose a lifestyle of being a vegetarian, and it doesn't mean that they're not going to get enough protein intake. Because what we know is the incomplete proteins can be added together to create a diet that's very complete with all the essential amino acids. So even though you have a patient who's vegetarian, we can still work with them to get them enough of the incomplete proteins that they will have enough essential amino acids in their diet. As we continue on with protein, we need to realize protein is broken down into amino acids in the small intestines by the pancreatic enzymes. Excessive amino acids are turned into fatty acid, ketones, or glucose. Our body's protein tissue, if we think about how our bodies work, we're in a constant state of flux. So these tissues are continuously being broken down and then we replace them. So again, that's why it's so important to have protein in our diet. Protein intake should contribute to about 10 to 35% of our total caloric intake needs for adults. And now we're moving on to fats. Again, another nutrient that provides us energy. And fats contain a mixture of saturated and unsaturated fatty acids. 95% of lipids in the diet are triglycerides. Saturated fat, when we think about what is a saturated fat, and all that means it contains more hydrogen than unsaturated fats. Saturated fats come from animal proteins and they tend to raise our serum cholesterol levels, where unsaturated fats come from plant proteins and they tend to lower our cholesterol. So when we're teaching a patient about that maybe they have some cholesterol issues, maybe their cholesterol is high, we want to teach them how to read a food label and to look at how much saturated fat are they having and how much unsaturated fat are they having. We want to teach them to pick foods that have more unsaturated fats because these will tend to lower their cholesterol. And then we have what's known as trans fats, and these are unsaturated fats that have been hydrogenized. And therefore, because of this process that we've done with them, they now therefore raise our serum cholesterol. So we also want to teach our patients to try to avoid trans fat as well. As we continue on to talk about fats, and I was mentioning earlier about how fats in the relation to cholesterol. Cholesterol is a fat-like substance. It's found in animal products. We do know that high serum levels are associated with atherosclerosis. It can lead to multiple health issues such as coronary artery disease, kidney disease, stroke. And so to help lower serum cholesterol levels, researchers recommend limiting that cholesterol intake, eating less total fats. Again, as I pointed out on the other slide, especially teaching our patients to look for saturated and trans fats. And we want them eating more unsaturated fat. And increasing fiber intake. What we found is an increase in fiber intake will increase fecal excretion of cholesterol. The dietary guidelines for 2010 Americans recommends that fat intake be no more than 20 to 35% of our total caloric intake. We're now going to move on to our regulatory nutrients, those micronutrients. And the first one we're going to talk about is vitamins. And vitamins we know are needed by the body in small amounts. They facilitate thousands of chemical reactions in the body, such as metabolism of carbs, proteins, and fats. They're present in foods, especially fresh, non-processed foods. And what we know is within the United States, vitamin deficiency is uncommon, but there are certain subgroups within our society that are more at risk than others, such as alcoholics, the chronically ill, and people that are just in general poor eaters. We know that they have a deficiency with vitamins in their diet. Vitamins can be classified, and the way they classify vitamins is by water soluble, which includes vitamin C and B. And this just means they're not stored in the body, but they're absorbed through the intestine wall directly. And then we have fat soluble. Those type of vitamins include vitamin A, D, E, and K. And we must, these type of fat soluble vitamins have to attach to a protein to be transported. And I think you guys can read the rest. I'm going to stop there with vitamins. The next regulatory nutrient we're going to talk about is minerals. And minerals are inorganic elements found in all body fluids and tissues. These can be classified into macrominerals and microminerals. Our macrominerals, we need daily amounts greater than 100 milligrams a day. And so these would include calcium, phosphorus, sulfur, sodium chloride, potassium, and magnesium. And then when we think about microminerals, these are needed in amounts less than 100 milligrams a day. So your iron, your zinc, iodine, fluoride, those type would be considered a micromineral. Water is our last regulatory nutrient, and it's a major body constituent, and it's present in every body cell. It accounts for 50 to 60% of our total weight. Um, this slide talks a little bit that 2/3 of our water is contained in our intracellular fluid of our cell. 1/3 of our water is contained in our extracellular fluid or outside of our cell. It provides the medium for all chemical reactions. So it aids in digestion, absorption, circulation, excretion. There are many sources, including beverages, food, and the recommended intake for adults is 2.2 to 3 liters a day. This slide is in here. It's about digestion. I'm not going to spend too much time with it. You can read this, but we go over digestion in our GI chapter or our bowel elimination chapter. And so you can also refer to that PowerPoint as well regarding digestion. So this box came from your book. It's box 36-2, and it talks about dietary recommendation or key recommendations of the dietary guidelines for Americans. And the big things we want to recommend is we want to recommend a healthy eating pattern. And when we say that to our patients, we mean that we want that to have a variety of vegetables, fruits, whole grains, fat-free or low-fat dairy, and a variety of protein packed foods. We want to teach our patients healthy eating patterns that limit those saturated and trans fats, those simple sugar foods, diets high in sodium. We want to limit these. We want to teach them to use alcohol in moderation. We also want to include guidelines for some physical activity. We want them to start engaging in regular activity. And so as you look at these, I would like you, we're going to go through a few, but we want to think about as we're teaching our patient, we have a patient in the hospital we're taking care of, what are some tools we can direct our patients to go to so they can choose some good choices? We're going to go over a couple here. I think there's one in the next slide coming up, but I want you guys to see what you can find out there. Are there apps that you've used that could help our patients make some good food choices and some dietary changes? Are there websites that you're aware of? And bring those and we'll kind of discuss and see what we found when we meet for class over this topic. So as I said, if we're teaching our patients about recommended dietary guidelines and where to send them to assist them with choosing good food choices, one place you can go is to choosemyplate.gov. And this is a food guide to kind of assist people with how much fruit and vegetables should they have, what portions of grains and proteins, and etc. So this is one resource. Again, I would like you guys to come to class and let me know if there are other resources out there that you have found that you could use to direct a patient in order to make good food choices. So food labels are also important to teach our patients. This informs consumers of the nutritional value of a food item. And so this allows for easy identification of fats, calories, sugars, proteins in the products we are eating. And so I don't know how many of you do look at your food labels. Maybe after you listen to this PowerPoint, the next meal you have, go and look at your nutritional labels. Jot down how many calories did you consume from that based on your nutritional labels. How many grams of fat? Was it more saturated fat or was it unsaturated? How many carbs were in that? And when we break down carbs, how many what sugar, how many sugar grams were there, and how much protein did that food have. And it'll be interesting to see if most of you, because of the stress of nursing school or what's going on, your busy schedules, you're studying all the time, has that changed your nutritional intake? And are you eating foods that are more high in sugar and calories than what you used to? There are developmental factors that affect our nutrition. The next few slides go through infants, toddlers, school age, adolescents, and we'll hit on a few things here, but you will not be asked any questions over infants, toddlers, school age, or adolescent patients. But this is just more that you have an awareness. You realize that infants, that's the most rapid growth period. The nutritional needs are greater at this time than any other time in our life. And just to kind of hit some of those milestones with each age group, that based on where we are developmentally, that will affect our nutrition. As we enter into toddler and the preschool years, our growth rate tends to slow. The mobility, autonomy increases. We have more coordination. We can verbalize our likes and our dislikes. We can manipulate food and now feed ourselves at this age. It's important that we realize that we don't want to use food inappropriately. We don't want to punish by taking away food. It's really recommended not to reward with food because this can lead to inappropriate food attitude. We also, with this age group, again, growth slows. We can be picky eaters. We can manipulate our food. And we see often that an inadequate intake of fruits and veggies are happening at this age. And we really want to be careful with excessive sugary drinks. The school age child, we start to see that appetite improve, but it's really irregular. When we think about this age group, we want to focus on high energy, yet nutritional foods because the body is preparing itself for the adolescent growth spurt here. So at this age, you might see the body accumulating reserves of more fat because of that growth spurt that's getting ready to come. The adolescence age period, this is rapid growth. We hit that growth spurt. Girls begin menstruation and experience fat deposits. Males experience increase in muscle mass, lean body tissue. This age tends to consume inadequate amounts of fruity vegetables and whole grain dairy. And so it's really important to teach this age group not to skip breakfast, to make sure they're making good food choices because often they make poor ones. So now we're into adulthood. As we get older, I feel like everything seems to decline. And this is true with our nutrition here. Our basic metabolic rate declines with each decade. Our nutritional needs in adulthood level off. And also, we notice our physical activity often declines, and that's due to demands of work and family in our adulthood. And growth has stopped at this age group. So we're no longer growing. As we become older adults, energy expenditures further decrease. Sometimes chewing becomes more difficult due to our oral health issues. Constipation is more likely, and that's just due to aging and decreased peristalsis. We may see thirst sensation decrease at this age. As I said, it seems the older we get, the more everything goes downhill. Loss of taste sensation between sweet and salty begins around 55 to 59. You may also see in older populations, they may have social isolation, maybe poor self-esteem or loss of independence, and that can affect our intake. At this age, it's important to remember that caloric needs decrease, but our nutrients needs remain the same. So we still need to make good food choices because we still need good energy sources, those good regulatory nutrients. We still have that need for that. We just don't need all the calories. As I already mentioned, other factors influencing our nutritional needs is that state of health. Anytime we have trauma, illness, that can greatly affect the nutritional needs we have. As I've already mentioned, alcohol abuse, different medications can affect our nutritional needs, as well as excessive ingestion of certain nutrients. We've talked about factors that influence our nutritional needs, and now we're going to switch and talk about factors that influence the food choices that we actually make. And these bullet points, the first one is economic. And as I discussed earlier when we were talking about carbohydrates, um, the cost of food can greatly limit one's ability to afford nutritional food. As we said, those simple sugar, carbohydrate foods tend to be cheaper. And if you are limited in what you can buy, then you will tend to go towards the food that is cheaper, but maybe not have the nutritional value that we want you to have. Religion impacts our food choices. Certain religions may have dietary restrictions on foods, such as alcohol, meats, um, or they may have special preparation or requirements, such as a kosher diet. The meaning of food. Sometimes we eat just for comfort. Some avoid foods or choose radical diets due to some stigma of weight. Some avoid food when they are when lonely, so that can influence our food choices. And then our culture influences the types of food eaten and how they are prepared. Necessary to customize diet plan based on our cultural demands. So those are just a few of the factors. The next slide we're going to talk about is some additional sociocultural factors affecting our nutritional intake as well. So additional sociocultural factors affecting nutritional intake that your book talks about include illiteracy, um, language barriers, the knowledge of nutrition, that piece that I keep talking about of how we want to teach our patients, because maybe there is a lack of knowledge regarding what types of food are best for them and what types of food they should avoid, or how do they read a nutritional label. The lack of caregiver or social support. Some, especially in our older population, live in social isolation. Is there a limited ability to obtain or purchase food? Do people live that you're taking care of? Are they living where there is not a grocery store, or they don't have transportation, and so they're limited in their ability to go out and shop? The lack of inadequate cooking and or food preparation arrangements. Do they have, um, you know, do they have a place to live that has a stove or an oven? Are they able to purchase cleaning supplies and keep that area where they're going to prepare food clean? So that can have an impact on their nutritional intake. The next two slides continue on about food intake. And one of the bolded terms in your textbook talks about anorexia. And this is a disorder where the individual does not eat. If they go long enough with denying themselves food, they will eventually have a lack of appetite. Sometimes anorexia can be secondary to some type of illness, possibly a medical or drug regimen that they're on, or some psychosocial issue. But decreased food intake may be related to economical issues as well, illness and surgical procedures. So being aware, anorexia is a disorder where there's a lack of appetite. They don't take in the appropriate amount of food. It is not always a choice. Sometimes, as I said in this PowerPoint, it may be a secondary or like a side effect to an illness or something going on with the patient. As far as increase in food intake, we did mention obesity. We've talked about BMI. Obesity is considered a BMI of over 30. Or obesity is considered weight is 20% over the ideal weight. It can be secondary to a positive caloric balance, meaning they're intaking more calories than they're expending. And the um, the numbers that your textbook gives states that about 2/3 of the U.S. population is considered overweight, and about 1/3 of our U.S. population is obese. So this is a problem we are seeing in society. As we discussed in the past slide, obesity puts us at an increased risk for certain types of diseases. So we do want to take an interest in our patients who are obese. We want to try to help them find a healthier diet and decrease the amount of calories that they're taking in. Your textbook talks about nutritional screenings. And again, this is a great assessment tool if we're trying to figure out what our client is eating and what are their needs. And so these screenings look for cues associated with nutrition problems to determine if a person is malnourished or if they're at risk for malnutrition. There is examples in your book of a mini nutritional assessment tool, and the MNA, as they refer to it, is used to detect older adults at risk for malnutrition. Um, and there are other types of nutritional tools that are listed here, but just be aware if you have a concern about a patient being malnourished, it is always good as a way to assess that patient is to get a nutritional screening for that patient. This just continues on with dietary data. We can look at a nutritional screening for cues of nutritional problems. We can assess on our own their dietary intake when we're doing intake and output. Very important. If we want to look at that, assessing their dietary intake, for instance, with a diabetic patient, we will document how many carbs they ate with their meal. When we're doing a dietary data, trying to assess that dietary intake, we can do what's called a 24-hour recall method where we ask the client to recall the food and beverages they've consumed. Another thing we could have patients do is keep a food diary and a calorie count, and they document in that each day. Food frequency records is another general pictures of types of foods consumed over a period of time, and then just obtaining a diet history, a comprehensive approach to determine what is their diet history. But again, you in the hospital, when we're taking intake and output, a lot of times we focus on with intake just the fluids that they're taking in, but it is always good to document what percentage of tray did the patient eat, because if we start to see a trend where we notice that they are only taking maybe 10% or eating about 10% of their tray at each meal, we might start to, that might cue us that there might be some nutritional problems or something going on with our patient. This is just a summary of medical and socioeconomic data that we gather on a patient most of the time when they are admitted to a medical facility. And again, these are questions we are getting from the get-go, whether we think there's a nutritional problem or not. But we gather information on their current illness, why they're seeking medical treatment. Do they have any history of medical or surgical history going on? Do they have any dependency on drugs or abuse? Further, we may evaluate, are they able to chew and swallow? How's their appetite been? We may want to ask that. The other thing, we were very good about asking about allergies in regards to medications, but we also want to ask about allergies in regard to food. Do they have any food intolerances? We talk a lot in the GI or the bowel elimination chapter about bowel habits, asking those questions when we're assessing our patients. Other demographic data that we gather when a patient comes in is their age, their family history, their lifestyle, their occupation, their religious affiliation. Do they use alcohol and tobacco? And other questions we may want to add on. Should we think that there's possibly a nutritional problem? that we may want to search for that data is, do they have a source of income, and do they have a food budget? Are they able to afford groceries? And do they have the capacity? Is there a place for them to grocery shop? Do they have the transportation for that? So those would be some economic data we'd want to gather. So this is about clinical data. What are we going to assess for on our patient? And your book talks about signs and symptoms of altered nutrition can be observed during a physical assessment, but we usually do not see them appear until the condition is advanced. Um, and your book, and it is not in the slides, or actually it is, I'm sorry, it's in the next slide. But there is a table. It's 36-2. It's on page 1298. And it has a really good table about clinical observations for a nutritional assessment. So we may want to look at different features. For example, I'm just going to give an example here. A hair. A sign of good nutritional status is their hair is shiny. It's not easily plucked. The scalp is healthy. And signs of poor nutritional status may be that their hair is dull and dry. It might be brittle, has loss of color, is easily plucked, and is thin and sparse. So that could be a sign of poor nutritional status. Another one, I'm just giving another example, is lips. Good nutritional status, our lips should be pink, moist, smooth, not chapped or swollen. And a sign of poor nutrition, lips may be swollen and puffy, angular, may have some lesions on the corner of the mouth, or fissures or scars. So just looking at our clinical observation can give us maybe some indication of nutritional issues. I think this is a great table to look at in your book. And as we assess our patients as well, we want to assess for, are there any barriers to eating? So dysphagia, difficulty swallowing, or the inability to swallow. And then we want to observe also for possible aspiration. This is the mid-direction of the oropharyngeal secretions or gastric contents into the larynx and lower respiratory tract. If we notice our patient every time they take something to drink, they have a coughing episode or fit, we may be an indicator that maybe they're aspirating. So we do want to assess for these types of barriers with eating. And this is just that table that I was referring to in the last slide. This table is 36-2, and it's on page 1298. Lastly, when we're assessing for nutritional issues with our patients, we always want to look at biochemical data, because that can have nutritional implications. These are different lab values. And again, we give you the normal range here in this slide. And we also state, with hemoglobin, if they have a decrease below 12, they could possibly be anemic, and that can have an impact, or nutritional impact. Serum albumin levels, if it's below a 3.5, that can signal malnutrition or prolonged protein depletion. So it's highly recommended that you look at these, associate these with looking at nutritional status on your patients, look and start to learn these normal values and what increases and decreases can mean, because you will need to know this knowledge as you enter the clinical setting and you take care of your patients. As I'm recording this voiceover PowerPoint, I am not sure where nutrition will fall in the semester. We have not made our schedule of topics yet, so I don't know if you've had the nursing process or if you've learned how to make a nursing diagnosis. But as I've said in previous voiceover PowerPoints, the nursing process is about assessing our patients. Based on the assessment data we gather, we determine if there is a problem. If there is a problem, we give that patient, based on what the problem is, a nursing diagnosis. Once we've done that, we've done a nursing diagnosis, we formulate a goal for our patient, we implement interventions to assist with our goal, which is usually the opposite of the problem, and then we evaluate whether we were successful. And so these are just from your textbook. These are nursing diagnoses that apply to patients with nutritional issues. You may have a patient who has imbalanced nutrition problems that are either less than body requirements or more than body requirements, or a diagnosis of obesity. You may also have um, imbalanced nutrition as the cause of another problem. For instance, your patient may have a nursing diagnosis of fatigue, and it may be related to um, them not taking enough caloric intake in. So this is just a slide to talk about that nursing diagnosis portion when we are thinking about our patients in the nursing process. What are we going to teach our patients? We talked a lot in this slide about finding resources, teaching our patients about caloric needs, about nutrients, about reading food labels. And so when we think about teaching, we know that a patient is more successful when their diet is individualized to them, to their lifestyle, their culture, their intellect, and their motivation. We always want to encourage or teach a client about safe handling of food, storage, and preventing foodborne illnesses. A little side note when we think about teaching is, when they're shopping, just to separate their foods during shopping. I don't know if you've ever noticed, like most of the time, people who bag your groceries will put your meats bagged in a separate bag and not with other things. If we're dealing with raw meat, we want to make sure that we're cooking it properly, that it's packaged properly, and stored away. Getting back to having the client be successful if we individualize their diet. A great resource is if you're in a facility that has a dietitian to get a referral from the physician for the dietitian to come in and really talk to that patient and help them come up with a diet that will work for them. As we think about further interventions that help with nutrition, we just talked about teaching, monitoring a patient's nutritional status. It's common in healthcare facilities, depending on what's going on with your patient, to have some orders that talk about advancing diet as tolerated. And for that, nurses we have to gauge the tolerance. We're going to assess for absence of nausea, vomiting, diarrhea. Do they have absence of abdominal pain or distension? What is their ability to consume over 50% of their meals? So those are some of the things we're going to monitor. It's very common to see a post-op patient come back and be NPO. And, we'll talk a little bit about this in the elimination chapter or GI chapter. But, if they don't have bowel sounds, we don't want to start feeding them because we're just going to have more issues with that. So we want to wait for that post-op patient to start having some bowel sounds. And in order to do that, we have to get them up and get them walking and moving. And then we might, if they start to have bowel sounds, we might advance them with clear liquid diet. We'll see how they tolerate that. How do they do with that? If they do okay with that, they're still having bowel sounds, they're not nauseated, they're not having diarrhea from it or pain, and then we might be able to gauge that and advance that order to a full liquid. So we really do, as nurses, have to monitor this nutritional status, and we have to observe those orders of whether to advance their diet or not. And there's several things we have to assess for in order to determine that. As we continue on with interventions, if we have a patient who's got really poor appetite, there are things we can do to try to stimulate that appetite as nurses. One of the things listed here is trying to serve small, frequent meals. So instead of having 3 big meals a day, maybe they are offered 6 little tiny, small, frequent meals throughout the day. We want to know that patient's food preferences and encourage favorite foods, and possibly, even if it's allowed, have somebody bring something from home if maybe they really can't stand the hospital food. We're going to encourage a pleasant eating environment. So, when you think about a patient's surrounding in their room and you take a meal tray into a patient's room, Don't sit it on their table, and you notice that they have a bedside commode sitting right next to them, and it's full of urine or feces, because just the smell and knowing that's sitting there, that is not going to encourage me to eat at all. So we really need to make sure that we are looking at our surroundings and our environment of our patients and encouraging that. Are we sitting them up? Maybe our patient doesn't eat because maybe they've got some problems with their range of motion in their hands, and maybe they can't open something. So are we offering to set up their tray so that it's easily accessible for them to eat? Are we controlling pain and nausea? If you are in a lot of pain or you're having any type of nausea, you're not going to want to eat. So we need to work on measures to try to control that. And we do really try to integrate home rituals as much as possible. If your patient usually doesn't eat lunch till 1, 2 o'clock in the afternoon, if you bring their meal tray at 11 o'clock, it's possible they're not going to be hungry and they're not going to eat much. So again, sticking with their routines of what they do at home is very important if we're trying to stimulate that appetite. If we're going to assist our patient with eating, which we do have to do sometimes, we're going to try to have our client do as much as possible. So again, maybe they just need assistance, like I said in the previous slide, with opening packages. Maybe that's all they need and they can do the rest. Maybe it's a matter of they're able to maybe lift their drink and drink with a straw, but they really have trouble using their fork, and they do need some assistance with you feeding them that way. So again, we always want to assess and try to have the client do as much as possible and not just take over, but we are there to assist them. When we have to feed a patient, we're going to sit at that patient's eye level, and we're going to try to engage the person in some pleasant conversation while we're there. We always can use, unless a doctor writes an order for some reason, not to use a straw, but it's okay with most of our patients to use a straw or some type of special equipment if needed. We want to make sure our patients have their dentures, their hearing aids, and their glasses in place to assist them with their eating. Again, opening containers or cutting meat up or applying condiments as the client wishes, very helpful. For the visually impaired patient, it's always good to set their tray up and explain the placement of their food. It might be wise to say your milk is placed on the left side of the tray towards the back. Your fish is in the front of the plate. And again, we can always be there to assist them. It's always good to provide some supervision as needed when we are assisting our patients with eating. If we are having to help a patient with feeding that has dysphagia, we want to make sure that that patient is sitting upright at 90 degrees. It can be helpful to provide some mouth care immediately before the meal. We're going to avoid rush or force feeding this patient. Allow them time when they take a bite to take a breath between it. I know in busy facilities, maybe long-term care facilities where staffing is short, you feel rushed and in a hurry, but force feeding is not good for our patients. It could be beneficial to get a nutritional consult with these type of patients. We're going to alternate with giving them a bite and then allowing them to have a drink afterwards. So we're going to alternate solids and liquids. We're going to assess for aspiration. We want to make sure our patients don't aspirate. So we're looking for that coughing or choking or clearing the throat while they're eating. We always want to inspect that oral cavity for any retained food afterwards. We could do mouth care again after that. And in order to help feed them better, we would try to avoid or minimize the use of sedatives or hypnotics before trying to feed them. As you guys get ready to go to clinical, it is important to understand what the different therapeutic diets are. These are just a few of them. as far as fat restricted, high fiber, low fiber. When we meet as a class, we will probably do more of an activity to go over these different type of diets. But these are in your book, and it is good to have an understanding of what that means and what that includes. Modified consistency diets. So you'll see patients on clear liquid diets, and basically, when we think of a clear liquid diet, we can pretty much see through the liquid. So that's any type of clear broth. That can be beef broth, chicken broth, clear fruit juices. But again, that's clear. So orange juice would not be on a clear liquid diet. Jello, popsicles, coffee, and tea are actually on a clear liquid diet. Now, the coffee would have to be black. You would not be able to put any cream or sugar in it, but it would be available on a clear liquid diet. Pureed foods, those are blended foods for a patient that may have difficulty chewing. Mechanically altered diet, the foods are chopped up, and it would be similar to like having ground beef. And MPO is, of course, nothing by mouth. And again, we will have a little activity we'll do as we meet as a class to discuss and go over these types of diets. As we get to the end of this PowerPoint, we have a few more slides here, but we're going to go into enteral nutrition. And this is what we consider gastric feedings. So a tube is placed into the GI tract and formula is administered. We can have what is determined as short or long-term feeding, and we're going to get into that. And there's a lot of consideration that goes into a patient with getting gastric feedings. There's ethical implications. We are not going to talk about all those today. And then just the client wishes. So the first one we're going to talk about is a nasogastric tube. You guys will learn how to put a nasogastric tube in during your skills lab. We use this when we're considering short term, so we're going to give patient nutrition less than 4 weeks. It's inserted through the nose and into the stomach. There are risks for clients to aspirate formula into the lungs. That's why it's so important to check that placement of the nasogastric tube. And you can also have a nasointestinal tube, which is a tube that's passed from the past the stomach and it goes on into the intestines. And those would be indicated for clients with increased risk for aspiration. Usually we do not see that very often. You will want to review your skills for this chapter regarding the insertion of the nasogastric tube, and as stated, you will practice the skill in the skills lab. As always, we want to assess placement of the NG tube before we begin any feedings. The gold standard for truly assessing the placement is to get an x-ray. I don't know that all facilities or physicians order an x-ray after you've placed a NG tube, but that is the gold standard. The other way that you can check placement is by aspirating gastric juices and testing the pH. A gastric juice's pH is greater than or equal to 6, and that's a pretty good indicator. Now, you will probably see in practice an older nurse. Myself was taught this method, and other nurses were taught way back when that to place a syringe at the end of the NG tube and push some air into it and listen in the abdominal area for that. We know now with evidence-based research that that is not the best way to test for NG placement. But it's not to say that you won't see an older school nurse do that. And I just always tell students to be aware that if you see a nurse doing that, that's the way she was taught years and years and years ago. But for your knowledge as a nurse going forward in the future of nursing, these are the ways, what we have listed here in this PowerPoint, for how you should test your placement of your NG tube. We always want to measure our tube length before feeding. So when you insert that NG tube, you're going to mark or note where it's at the nares. You're going to tape that, and you're going to want to document that because the next nurse coming on is going to want to make sure that that tube is still at that marking, so that we can know that the placement is correct. This is a continuation of the nasogastric tube. The previous slide I did talk about checking tube placement when an NG tube is inserted. We also want to check for that tube placement before each use. Um, Obviously, you get an x-ray before the first use, but before we start giving feedings or anything through that, with each additional use, we want to aspirate gastric juices, check the length and to compare to the insertion length, and check for residual. And that's going to promote safety with using that NG tube. We're going to do an abdominal assessment when we have a patient with an NG tube. We're going to check for bowel sounds. Do they have abdominal distension? Is there any pain, nausea, or vomiting? We want to keep that patient upright during the feeding, so the head of the bed as high as tolerable, but we want to have that at least 30 degrees. If for any reason we need to lay that patient down flat, we need to pause that feeding. We're also going to pause the feeding and remove from the client during medication administration. We never administer a med through giving a formula or a feed through the NG tube. We're always going to flush that tube with water before and after any medication administration. And another important note to make, we always want to make sure too that we are keeping that patient sitting upright at least 30 minutes to an hour after their feed is complete as well. Comfort measures for a patient with an NG tube. You're always going to want to do oral care every 2 to 4 hours. Let them rinse their mouth, lubricate their lips. Oral swabs are very helpful in keeping their mouth moist. We're going to make sure that their nose is clean. If we need to, if there's dryness around that tube or it's causing some discomfort, we can use some lubricant around the tube. We're going to encourage our patients to verbalize their feelings about the tube. We know they may not like it. Again, NG tubes are used for short-term use. And we're going to ensure that our tube is secured to the patient's nose and to their gown as well. And then when it comes time for removal of the NG tube, this skill is also, it's actually in your bowel and elimination chapter, but I've noted it here in the PowerPoint. We're going to always check for replacement before removal and flush with normal saline water after checking for placement and prior to discontinuing the tube. This helps remove the feeding and any gastric juices that could be in the tube that would come out as you pulled it out. We're going to clamp the tube prior to removal. This helps prevent aspiration. And then we're going to assist our client with cleansing their mouth following that tube removal. If we're considering long-term nutritional support, the physician and the patient will consider an interstomal tube, which may be placed through the opening in the stomach or into the intestine or the duodenum area. If long-term nutritional support, as I stated, if it is decided to place a tube in the stomach, you may see what's called a PEG tube. And this requires that the patient has a functional GI tract, and they measure length regularly and compare to the insertion notes and length when they place one of these PEG tubes, or you may even see it called a PEG and a J tube. And so again, we are measuring for that placement in that site because we are going to regularly compare the length of that tubing to the notes within the procedure. When we administer enteral feedings, so when we do this, if a feeding is going into the intestine, we are always going to make that continuous because we want to avoid what's called dumping syndrome. And dumping syndrome is caused by an overdistension of the small intestines. So if we were to take an intermittent feeding, which is like a one-time feeding, and dump all that into the intestines, that would provide larger than normal amounts of food and liquid in that small intestine, and it would not be absorbed and it would be dumped. So when we have a feeding that's going into the intestine, it is going to require a feeding pump, and it will be set so that it runs at a lower dose and goes continuously. If we have a feeding that is going into the gastric or the stomach area, then it's okay to have intermittent feedings, and that is the preferred method for that placement. And with intermittent feedings, they're on a regular scheduled regimen. They will get equal proportions of formula at each feedings. Usually the feedings, the preferred method is to give it by gravity. So you'll take a syringe and the formula, and you'll connect the syringe and pour that formula in and allow that to go in per gravity. We do want to watch with syringe feedings. This can cause aspiration and distension. So we do want to be aware of that. We do want to sit our patient up when we're doing these feedings. Other options include cyclic feedings, and this is where you're administering a continuous feeding for a portion of the 24-hour period. So sometimes we'll do a cyclic feeding, so maybe the first 12 hours of the day they're getting that feeding, and then we'll stop that feeding for the second 12 hours of the day. So that would be another example of options for feedings. As we continue on with this topic, it's important to know enteral feeding formulas. A lot of consideration needs to be placed with this because they can be very expensive, the cost. What is the availability to the patient? Are there any allergies or food intolerances or medical situations? We have to consider all that when we're trying to determine the best enteral feeding in the formula. The standard formulas that we normally give contain the requirements of protein, carbohydrates, and fats required that the patient should have for normal digestion and absorption. Hydrolyzed formulas will contain proteins and other nutrients in simple forms that require little or no digestion. So again, there will not be a test question on this slide. It's just something to think about. And if you have a patient that's going to have some type of feeding tube placed, and the type of considerations that are going into that, and in regards to what type of feedings they will have. When we have a new patient with a feeding and we're going to begin that feeding, we always want to begin feedings at full strength of formula. We're not going to mix with water or other liquids unless for some reason it's been ordered to do that by a physician. We're going to always begin those feeding rates low. We don't want to start off at full capacity. We need to see how our patient tolerates it. So generally we'll start those feeding rates at 10 to 40 mLs an hour. Again, each facility you're in will have a policy regarding beginning of feeding, and that will kind of guide your practice, those facility policies. You're going to check the client's tolerance, and by doing that, you're really checking for signs and symptoms of, are they having any abdominal distension with this? Are you noting any signs of aspiration? Are they having absence of diarrhea and constipation? Is there a presence of bowel sounds, and are those bowel sounds within normal limits? We're going to check the residual by aspirating contents of the stomach, and we're going to note the amount of formula left in the stomach, and then we're going to follow facility policies with regards to residual amounts and advancing or holding the feedings, because that, if you're having large amounts of residual, it probably means they are not tolerating that feeding very well. Normally, any residual more than 200 is recommend that you do not advance, and you may even want to hold the next feeding. We're always going to advance the rate slowly. So when we advance it just by a little bit, maybe 10 to 20 mLs an hour, and we're going to advance it maybe every 8 to 12 hours until we get them up to the ordered full capacity. But again, it's very important with beginning feedings that we are assessing how that client's tolerating it, and we are starting those feedings at a low rate. So this ends our PowerPoint presentation. Hopefully you've taken notes. I've given you a few activities to come to class with. It's very important that you go through and review your skills that are listed here, as well as the NG tube skills that are in chapter 38. I look forward to discussing this topic with you in class. Thanks.